Welcome to this video presentation of a total laparoscopic hysterectomy with bilateral salpingo-oophorectomy for a 48-year-old patient presenting with complaint of abnormal uterine bleeding. The patient has history of previous 4 surgeries, of which 3 were LSCS and 1 was a lap chole. The patient is known case of hypothyroidism, hypertension, and diabetes mellitus. All the 3 conditions medically managed. And the patient was quite obese with a BMI of 32. So, as we entered the pneumoperitoneum, the cavity, it was clearly evident that the uterus was severely anterofixed to the anterior abdominal wall. As you can see, it's not a band of adhesion, rather complete tissue, and it's quite thick. So we started the dissection from the safe point using the harmonic ACE, and it's a miraculous instrument in laparoscopy because it provides a minimal dissipation as compared to other energy sources, monopolar and bipolar, for example. So we played safe, taking most of the dissection towards the uterus because in my short experience so far, I firmly believe that while performing hysterectomy, do not hesitate to protect the vital structures, even if it costs sacrificing a part of the uterus, because ultimately you are doing a hysterectomy and protecting vital structures much more of importance than protecting the uterus per se. Well, after localizing the plane, gradually perform the blunt dissection and separation of the plane of the anterior serosal surface from the anterior abdominal wall using the grasper, suction, and the harmonic ACE. Followed which we perform the steps for the bilateral salpingo-oophorectomy, ligating the infundibulopelvic ligament using the bipolar energy source on both the sides. So after ligating the infundibulopelvic, we perform the cutting using the harmonic ACE on both the sides, ligated using bipolar first to save some time of switching the instruments, although we obviously have to switch sides. After ligating the infundibulopelvic, we started the incision using harmonic ACE and trying to localize the plane in the serosal surface from the peritoneum. And as you can clearly see in this video, there are multiple bands of adhesions still remaining on the surface. We were able to dissect the anterior wall quite well, but the lateral band and on the margins, these bands were providing quite a restriction to the further steps of the surgery. So ligate those bands along with the gradual anatomical structures. So as you can see, there's this another band, and we carefully inserted the harmonic ACE while firing using the active blade to make space for the entry of the instrument, followed by dissection of this particular band per se. Even the initial anti-abdominal band was dissected using the active blade, entering using the active blade inside. Well, this band was quite a tough one and refused to go after a single dissection, so we had to dissect it further and then gradually trying to pull down. Again, this major band in the central portion again had to be dissected using the harmonic. We fired the active blade, entered the space, and then pulled the band down. So as you can see, the cervix of this patient is quite long, and I personally prefer going as close to the uterus and cervix as possible to manage space for the vault and the suturing part, and more importantly for the safety purpose. So after this, we perform the skeletonization and the ligation of the uterine vessels. Again, we had to face some bands present over the peritoneal surface and perform the same steps as mentioned earlier, using the active blade and then pulling them down gradually. So as you can see, the bands going down quite well. And then using the harmonic case, there was a small bleeder, ligating it using the bipolar again. Again, harmonic, bipolar, harmonic, bipolar. So you can realize, differentiate by now, the color texture per se of the cervix has drastically changed. What it was initially in the surgery, quite pink, and gradually turned into nearly white. And now the monopolar hook takes the entry because we have separated all the bands quite well, ligating it, cutting it along the cuff, the monopolar hook, and again some vessels. So bipolar for the safety, saving the uterosacrals because we don't want the patient to land up in a wall prolapse. So giving a nick using the monopolar before the uterosacrals so that the wall gets support from the uterosacrals. And then again, we had some bands on the right lateral side of the patient, and he again had to apply the harmonic rather than blindly going using the monopolar in such thick tissue. And after that, completing the dissection, taking out the specimen along the vault, some bleeders was managed. After which, we took barb suture, and coincidentally, the loop of the barb suture was damaged during insertion. So we managed this one without a loop at its end. So we took the first needle through, then after the second one, we made a loop, took the edge without a loop, and then pulled it through, locked it quite well, and thereby preventing the need of a loop, which we usually get in a barb suture. Then normal wall suturing. So the barb suture locked quite well with that, even without the loop. So after getting the good grip on the first loop, perform the wall suturing. The wall wasn't big, required 3 sutures and one in the end for additional safety. After being done with the endo suturing, just checking the hemostasis, giving a gentle wash and suction, and finally we're done. Thank you.